Great. Now I'm excited to introduce and welcome our presenters for this afternoon, Dr. Marvin Gordon, Regional Director of HealthNet, and Dr. Neil Solomon, Co-founder and Chief Medical Officer of MedZed. MedZed has been a longtime partner of MHPA, and we thank them for their efforts in organizing today's session. We also appreciate their continued engagement and support of MHPA and our member health plans. Dr. Gordon and Solomon will be presenting today's webinar titled Plan Provider Collaboration, a trust-based model for better cost-effective care for high-need members. With that, I will go ahead and turn it over to Dr. Gordon for a more in-depth introduction.
So this is Marv Gordon. I'm a board-certified internist gastroenterologist by training. And as Eric mentioned, I am a regional medical director for HealthNet, where I've been for about 13 years. I practiced for about 20 years in Laguna Beach, California, and I'm the co-director and co-founder of HealthNet's Care Connections Palliative Care Program, and I've done several publications on palliative care. Neil, you're on.
Thanks, Marv. Hi, Neil Solomon. I'm an internal medicine physician. I'm the co-founder and chief medical officer of MedZed. We'll talk a little bit more about who MedZed is in just a minute. I've practiced in a variety of settings as a primary care doctor, a hospitalist, in skilled nursing facilities, and now on our platform. I've done a fair amount of palliative care, both patient care and organizing our program and mentoring some of our other clinicians in that program. Marv and I have actually known each other for more than a decade, which is part of what makes all of this work so well, is that there's a level of familiarity, trust, and comfort with each other, and we're good friends. Today's program is both about how to build a successful collaborative between a provider and a plan, and then it's also using the palliative care experience that MedZed and HealthNet have together to demonstrate what that looks like. So there'll be a fair amount about palliative care, but there's also the overarching theme of how to build successful collaborations and what they bring as a result. So I'm going to start there. The HealthNet MedZed collaboration is now, I would say, a pretty long-standing one in healthcare terms. We have been working together for 6 years, and we have a variety of programs, initiatives, projects that we've done together. Some we've completed, some ongoing, others planned for next steps. But there's an intertwining of the organizations and a familiarity. As I mentioned, Marv and I have known each other for a long time, but there are a lot of people in both organizations who have gotten to know each other well and feel comfortable and trusting of each other, which is a huge piece of building a successful collaboration. MedZed has 3 components, 3 different service opportunities that we deliver for various health plan clients, and we do all 3 for HealthNet. They're shown on that slide. We have a longitudinal social care program, which in California is now known as Enhanced Care Management, or ECM for short. It grew out of the Federal Health Homes program. So it's a longitudinal social program where community health workers support individuals with complex needs, and those individuals continue to use their existing provider network. And we help them to make appointments, get back to those appointments, but importantly, do a whole lot of other social non-medical things for them. The second program integrates that social service with medical care. So we deliver both in a longitudinal team-based model of care using a remote telemedicine-enabled model to be in the home and allow our providers to also make rounds through very diverse populations that may be spread out in a very efficient way. And so that's a longitudinal integrated medical and social program. And then the third one uses that similar platform, but adds additional services. And that's the palliative care program that we're going to describe today. It was born out of some regulations, actually a law that was passed in California that clarified what we all ought to start with. But HealthNet, as Marv will tell you, became a lot more dynamic and expansive in their view of that. So those are the three programs we offer. We do all of them with HealthNet. And one of the interesting things is that sometimes patients get moved from one to another program because their needs change. They may become more stable and only need social services, or their medical illnesses may advance and they need to be in the palliative care program. And they don't have to sort of learn a whole new set of services and people. There's continuity. So some of the things that help with building the collaborative partnership I've already touched upon, and that is developing long trusting relationships among individuals. So our organizations know each other, but there are people in the organizations who have gotten to know each other quite well. And that makes a big difference. That level of comfort and trust in what we're saying and where we're coming from, and being able to share things or ask things in a very real way is important. The fact that we have an array of different opportunities that we present to HealthNet sometimes and say, hey, we've developed this, would this be helpful to you? And they say, nah, we don't need that one, but if you could amend it and do it this way, it would make a big difference to us. So having a suite of services has helped to build the relationship. And then the fact that we can interrelate these programs, I think, has been helpful to HealthNet as well, since they are responsible for these patients across the care continuum. And so they can have a sort of a single point of entry for patients, and it's also easier for them in terms of contracting. So those are some of the key things that allow the partnership to thrive. And I will say that we have done everything from formal RFP submissions to brainstorming with HealthNet on what the next iteration of some of their programs should look like. So everything from pretty formal stuff to relatively informal, almost like shared consulting kind of strategies together to try to come up with programs. So we have a bunch of stuff that's ongoing now, and we're going to focus now on the palliative care. So I'm going to hand it to Marv to sort of set the stage on Pally now.
This is one of my favorite slides. It's labeled the not so secret sauce of palliative care. And this is right out of New England Journal, again, prominent journal in the United States. This was a randomized controlled study about palliative care in metastatic non-small cell cancer of the lung. An interesting study. No one was surprised that when you compare members who are getting standard oncologic care, one group gets early palliative care, one group does not. The ones who received early palliative care, they're less depressed. They use the hospital and the ED less, better quality of life, even though less aggressive treatment. And everyone goes, hey, yeah, palliative care works. And then came the big surprise. The palliative care members actually lived significantly longer than those not receiving palliative care. And this kind of shocked everyone. Now, I'm not saying that palliative care will prolong life in everyone with severe progressive disease, but I think the one thing it points out, you definitely are going to have an improved quality of life, even though less aggressive care, and it surely does not shorten life, because that's what everyone thinks. Oh my goodness, this is like hospice. You're on the downhill. And the answer is no, this is about the living, not the dying. And again, that distinction between palliative care and hospice, will continue to talk about that. But again, this really is the basis for saying, is palliative care the right thing to do? And you'll hear us saying that over and over. Yes, it is. So if you're wondering, how did we exactly get into this? If you want to go into the next slide, Eric, it's really for us in California, started back in 2014 when our legislature passed the Senate bill SB 1004. And what this said is all Medi-Cal, which is California Medicaid, adult members will have the benefit of palliative care. So it's an actual benefit. HealthNet looked at palliative care, looked at the literature, and we said, we actually agree this is the right thing to do, but we're going to also do it for some of our Medicare and commercial members as well. And as we'll talk about later, it is definitely cost effective. And that's what's in the literature to lead us to say it's worth doing. So not only is it the right thing to do, it's cost effective as well. And then of course, the next step is when you do it, you've got to find the right providers that you can work with. And MedZed, of course, was a group, as Neil said, we know them, we've worked with them, we have history, we trust them. And it made it, I might say, fairly easy to roll out the program when you have great providers. So if you go on to the next slide, you can see how do you get that framework of trust? And the key things for us at HealthNet was clinical leaders led this. In other words, doctors, nurses, social workers, the people with hands-on experience with members created this. So it tends to be very practical, doesn't get into, we're careful about the regulations, but we're not focused on just regulations. The key is that cooperation and collaboration between organizations. And that's when Neil says, we've known each other, we trust each other, we work together, we coordinate. And the key is, as opposed to hospice, palliative care is an additional layer of support. So the member still has all of their regular doctors. They have a PCP, they have their specialists, they can get chemotherapy, they can get radiation. But in addition, there's another team, the MedZed team. They provide support and a much more hands-on in the home, being there 24/7, they provide that support. And then we have to make sure that everyone can coordinate on what we do. Because again, you have the health plan, you have the palliative team, you have the usual medical providers. And what we did is we built this into what we call patient-centric contracts and patient-centric operation so that we're not mired in regulations or data. We really want to make sure the contract allows us to take care of members and the operation is pretty straightforward, as Neil will explain what we do.
Actually, if you can go back for one sec. Yeah, so Marv referenced the contract, which is a really nice document that, excuse me, that lays out the services that we're expected to deliver and at a rate that we all can live with, that is beneficial to us and beneficial to HealthNet. And there's some specific pieces on the bottom of that slide that we wanted to call out. One is that in the what are the services, it lays out tiers. Different patient profiles are expected to or entitled to get different intensities of service, frequencies of visits, types of providers, that kind of stuff. And so it makes it pretty clear what the different profiles will receive. So both HealthNet knows it and we're comfortable with what we're delivering. Secondly, we meet, boy, I've got a frog in my throat. We meet, and I mean Marv and his team and my team, we meet on a very regular basis. So twice a month, we get together to discuss the most complicated and needy patients. One of those months is new patients added to the roster, and the other one are people who have been in the hospital recently and what's going on with them. And it is a give and take, it's a collaboration. Marv and other clinicians on the HealthNet side are asking us questions, what was his liver function test like when he was in the hospital? Did he get the imaging that he needed? Did his advanced directive change while he was in the hospital? Are all of his social needs being addressed? So we're back and forth, and sometimes we need help with this medication was denied, and we didn't understand what the formulary was doing there. Can you help us understand that? So there's a real give and take and problem solving together in clinical rounds, which is a great representation of the kind of collaboration that we have. In addition to those bi-weekly or semi-monthly rounds. We have a quarterly joint operations meeting, which is much more focused on the population, on process, on opportunity. And it's not just about palliative care, it's actually across the spectrum of programs that we deliver together. And we provide population-based reports, statistics, dashboard of how are things going across the program. So in the palliative care program, it would show among those who you referred to us who need palliative care, how many were we able to find and enroll? What's the average duration of time on the service? What is the satisfaction of the patients with this and their families? What proportion of those patients have an advanced directive that's been completed? And among those, what do they look like? Are most people asking for full care, or many of them DNR? What in between? So we're talking about population-based outcomes, and we're using that to explore opportunity together. And then it all kind of boils down to a case rate. And as I said, that's just a number. That's an amount that we can live with. We can make this a viable, long-term, successful operation, and HealthNet can afford to pay it. And in fact, based on what we know about palliative care, there's a return on investment for them, because these patients not only are healthier and happier, they actually end up costing less because they don't go to the emergency department and get hospitalized as often. So that's kind of the concrete components of what the partnership looks like within palliative care. Okay, so now in the next slide, Marv, I think you're going to talk about how patients get into the program, and then I'm going to talk about what happens next.
Correct. So if you wonder, where do we find the members? And I can tell you, speaking to other palliative programs in California, everyone is struggling with how do you find the members who really would benefit from palliative care services? And we usually think of high cost, high risk members, but how do you find them? I can tell you that we just had a discussion the other day, and the groups, the different plans range anywhere from, say, 14 referrals per 100,000 members to 170. But that's still really low for those who could benefit. And remember, who benefits? Severe progressive disease, using the hospital and the emergency room to manage their care, where probably the prognosis, or even using that surprise question, would you be surprised if this member would die in the next 1 to 2 years? It's, again, not hospice, but again, it's toward the end of life. Those who have advanced care planning issues, which is advanced directives or the pulse, or need a support. How do we find them? So one is, the providers who are out there will refer them. Oncologists, nephrologists, cardiologists. Again, we get out with brochures, webinars. I think a key is to make the referral process easy. For example, someone can literally call our line, talk to a nurse or social worker, ask whether they think the patient qualifies, and essentially make the referral on the phone, or we have a form. But again, easy. We know the providers out there are busy. We don't want this process to be burdensome. And the other thing to remember is you have to continually talk about palliative care. Remember, the offices, even here at HealthNet, we have employee turnover. So 1 year from now, the people we spoke to, a lot of them may be gone, and the new people have not heard about it. So one is direct referrals from the providers out there. Another is, why not do claims data mining? And we say, we're just going to use some of our tools like iPro, which is a risk stratification tool, or the Charlson Index, or simply high cost. We're going to find those members, and let's see, how many we can refer into palliative care. Turns out, not a lot is the answer. And one of the problems is claims data is lagging time-wise. Remember, your patient who gets sick comes to the hospital, then is discharged. The hospital generates a claim, we pay the claim, then we enter in our system, then we run a report. So between the time the patient had the sentinel event and when we identify them could be several months. And we know in this population, several months, I hate to use the same, could be a lifetime, but yeah, a lot happens in several months. So claims data mining sounds good, doesn't work as well as you'd think. And then we looked internally. And what we discovered is about 54% of our referrals are coming from our health plan nurses, either the case managers handling the sick members, the concurrent review nurses seeing the members in the hospital, or the transition care nurses who are helping with the discharges. Advantage here is we have them real time. They're identified immediately, and the member is actually in a facility often where we can actually speak with them, make sure we have the right contact number. Then they start to get the idea. It's not just a computer program. It's not just a phone call. It is actually real live people who want to help out and care. So again, the process, keep it simple, straightforward. You can tell the criteria: severe progressive illness, using the hospital and ED to manage their illness. That surprise question, they're towards the end of life, but not like hospice, where at the end of life. Advanced care planning and support. Now, once you identify, then we can say, Neil, how do you engage them?
Just because they look like they're a good person on a list or a referral form doesn't mean it's easy to find them and to engage them and to enroll them in the program. So that's where we come in. Before jumping onto the right side of the slide, though, I will highlight what Marv said with one example, which is that among those different sources, one of the weakest sources of referrals so far in the program has been other providers referring patients in, which is surprising because they see these patients, but they often don't think of it in the moment, or they don't realize that the patient could get this additional service and benefit on top of what they themselves, say a specialist or whomever, is already providing. And so together, HealthNet and MedZed identified a large hospital in Central California that has an inpatient palliative care service, but almost no outpatient palliative care service. And we've been working with them, sort of double teaming them, Marv and I, their medical director, to make referrals into this program and to make smooth, successful handoffs, transitions from inpatient palliative care, where they're doing work, to the outpatient setting. And then, of course, if the patient were to be readmitted for some reason, we could make the transition back to that same team. And so that's an example of how we've identified an opportunity and worked together to increase referrals. I would say that that's in progress. We haven't been totally successful yet, but we've made some progress there. On the right side of the slide, so once we receive the referrals, it's our job to then track these folks down. If we can find them while they're still at the hospital, that's the ideal time, because they're both a captive audience and someone's got a question. Okay, so if they're a captive audience and also at a teachable moment. So they're most likely to say yes, and we can find out where they'll be when they go home and follow them there, get there shortly after they arrive home to make sure there's a smooth transition. But a lot of these patients, we may be referred to us not while they're in the hospital. And because many of them are in challenging situations, the majority of them are Medicaid patients, and some of them have issues around unstable housing and things like that, they can be hard to find. So our job is to do all the detective work to track them down. And we think we're very good at that. We've made a sort of a whole science of how to reach people, starting with the simplest things like telephone calls. And then when those don't work because people don't recognize our number, or their phone no longer has minutes, or for whatever other reasons, we have a whole host of strategies to find them in the community. It might be at the residence, the address we have. It might be through connecting with neighbors, or a community or church-based group, and a variety of other strategies. So, and we're incredibly persistent and well-connected in the communities to find these people. So that's the first step. The second step is, once we engage somebody, once we find someone, we have to develop a relationship with them. If we sort of show up as a stranger that they've never met before who's offering services, you might imagine they'd be skeptical. And so we have done a lot of teaching and training to help our community health workers and our nurses to engage people successfully. We also intentionally choose people from the communities that we serve as our employees, so that there's a comfort level, a familiarity, an ease. Similar languages come from similar places, etc. So there's a cultural concordance, which helps with relationship building. And then we explain the benefits that they get, that they're free, that they're on top of what they already are offered by their health plan. And most of the time, people are certainly willing to try. And once they try, they almost always say, hey, this is a great thing. I can't believe I get this extra service. So there's a whole set of steps to go from identifying a name on a piece of paper or on the computer to ultimately enrolling them. But those are some of the strategies that we use. And once they're in the program, well, then there's a whole host of medical and social supports that we deliver. Okay, if you could go to the next slide, Eric. So this is a case study just to kind of make it a little bit more real. This is a man morbidly obese man, who when he was referred to us back in 2020, relatively early in the pandemic, had been using the hospital a lot. You can see he was hospitalized 7 times within a 9-month period, mostly for shortness of breath and anxiety. That was usually a function of heart failure out of control. But he had a lot of other conditions too. His chronic kidney disease contributed to the fluid imbalances that led to shortness of breath. He also had intrinsic lung disease from obstructive sleep apnea and COPD, which made it even easier for unfortunately made it easier for his lungs to fail when they started to fill up with fluid. And he was sort of a late stage heart failure patient who was confused about his medicines and feeling kind of uncertain about his future. It took a lot of kind of relationship building, education, and support for him to start to turn things around. We had to also tell him that because he has heart failure and COPD, and his heart failure is pretty advanced, that, a lot of people with heart failure, their life expectancy is not as long as it would be if they didn't have heart failure, and that we wanted him to be sort of understanding where he was in life's journey. So there was a lot of stuff that happened in those early stages. We also made sure that he had a more consistent relationship with his cardiologist and his pulmonologist. And we were able to set him up also with behavioral health support. He needed to understand where the anxiety was coming from, and to get more skill sets to address, to be able to identify when he was starting to feel anxious and to have personal strategies to deal with that. So part of it came from shortness of breath, or fearing that he would become short of breath, and what that felt like. So there was a bunch of stuff that happened. And once he started to get both his medical and behavioral health issues under control, his utilization went down pretty dramatically. So he went from 7 admissions in 9 months to 2 admissions in 18 months. And he was doing quite well. He then had a bit of a flare. He became anxious again in the spring of 22, and had 2 more admissions that were largely around anxiety. He got into a program to teach him very formally coping skills around anxiety. We were able to optimize his meds, and he became really pretty stable. His breathing improved. His heart failure symptoms went down. He actually felt so much better that I don't think he met the criteria, Marv's criteria, of the surprise question anymore. And we said, while he does have advanced illness, he's a lot more stable now. And he was actually transitioned out of the palliative care program and into HealthNet's case management program with a more intensive behavioral health set of services. But he didn't need us in the same way anymore. So, it was about 1.5 years that we were working with this gentleman, and he's doing a lot better now. This is actually an unusual path. Most of the people with palliative symptoms don't get to a place where they get dramatically better and transitioned out of the program. But this was a success story that kind of exemplifies that. Eric, if you could advance. Great. All right. So this next slide talks about what happens in those rounds that we have together. And you can see Marv as the medical director, his case manager, behavioral health specialist, sometimes a clinical pharmacist, and the managed care operations specialists attend those meetings. On our side, our lead palliative care provider, our social worker, our case management, our care coordinator, and a clinical operations leader all attend those meetings. And we would have talked about this gentleman we did talk about this gentleman on more than one occasion as he progressed and as we explored opportunities. And certainly when we said, you know what, he's stabilizing so much, we think he can succeed in other programs, that we brainstormed together. And that's how we ended up in that enhanced behavioral health and the HealthNet case management program. But we usually bring somewhere between 6 and 10 patients to an hour's long rounds. And we discuss those patients in detail. We present the case, the sort of the profile of the case, the active issues in the case, and any specific active questions we have for HealthNet. And then usually Marv, sometimes his colleagues, then chime in and ask clarifying questions, make recommendations, poke us and prod us if he thinks there's opportunities we've missed. And we come to some new resolution. We capture those recommendations. We send those recommendations to the team that's responsible for that patient, and they have them in their task list as next steps. So there is no sort of dropping of balls. And then if there's active issues, we'll bring that patient back to a subsequent rounds to close the loop. So that's how the rounds usually work. And I would say that we do rounds, maybe not quite as intensively as we do in palliative care, but we do rounds sort of like this with most of our clients in all of our clinical programs, because we find that the collaboration really helps.
So what I want to talk a little bit about is, well, how do you measure how good this program is? So here are a number of things that actually are meaningful and they're measurable. So if you look at the advanced directive, remember, 2 key things here. One is who would make decisions if you cannot, and the other is what are your preferences? And probably everybody should have it. And I would hope that we've learned from the COVID experience, regardless of age, you probably need an advanced directive. Then you go to the POST. Remember, that's the provider orders for life-sustaining treatment. This is actually a doctor's order signed by both the provider, because like in California, physician's assistants and nurse practitioners, as well as MDs, DOs, could sign this. So it can be a provider or physician order for life-sustaining treatment. Again, it's a little more than just a DNR, because again, you could say, I want, I'll give you an example. If you said resuscitation, well, resuscitation, there's several things. Would you want chest compressions? Would you want intravenous medication? Would you want cardioversion electric shock? So you really have some choices. Being on a ventilator, would you want to be on a ventilator long-term? Do you not want a ventilator no matter what? Do you want a trial of a ventilator? So it gets much more nuanced in what are we actually talking about? And rather than just saying, what are your preferences? What are the doctor's orders on what to do? Because we have patients who say, I do not want to be hospitalized. Others, I don't want transfusions. I don't want intravenous medication. So it really gets into what are the patient's wishes. And then, of course, the idea behind the POST is this is the vehicle by which we can honor those wishes and actually follow through, whether it's the EMTs coming in the home, whether it's the ED physician, whether it's the physicians in the hospital, or as we're talking about, or home-based outpatient care. We also monitor satisfaction. And I can say that when we last looked at it, we had about 3% who are actually dissatisfied. And I'm kind of thinking that's a good number because if you think about it, this is a very emotional time. And people sometimes are letting emotions run way ahead of logic and thinking. So I expect that some people are just going to be upset. Remember all the stages of death and dying? Some are going to be angry. Some are going to be blaming. Some are going to be depressed. So to only have 3% who are really dissatisfied with the program, I think is doing pretty good. And of course, the other problem we have, though, is to remember palliative care is in addition to everything else they're getting. So we're not taking anything away. It is not hospice. We're simply adding that extra layer. We've talked about the engagement rate. It sounds simple. Yeah, you find these people, why wouldn't they want it? I mean, think about the New England Journal article. In fact, I always say, if palliative care were a new drug, and I said, I have a new drug available. It's when you get towards the end of life, it will improve depression. You will have a better quality of life. You will not be in the hospital in the ED as much. So you're going to actually feel better, and maybe you actually will live longer. People would be clamoring for this drug. They would probably pay a lot of money for it. We are basically giving away palliative care for free, and we can't always convince people. So palliative care is a difficult subject. It's not a sexy subject. People don't want to talk about it. It's not the thing that appears in headlines. I mean, think about the whole COVID epidemic. People dying in hospitals. Hospitals are basically filled to the gills, patients in the ICU and ventilators. And did you hear a whole lot about end-of-life discussions? No, I think I saw one article over a 2-year period on that issue. So it's just something people don't like to talk about, but it's important and it is the right thing to do. Now, you also ask, what happens to these members? Well, some actually never go on the hospice. They will actually die while still on palliative care. And again, that is their choice to have their usual care plus the extra layer of support. On the other hand, some patients, when we present palliative care, will actually want to go on hospice when they understand what the two things are. Some, after they're in palliative care and as things change, then they may say, yeah, I think it's time to move over to hospice. So that's not unusual. Again, we have some patients who move out of the area, some who change health plan. We have some members who just say, I don't want the support anymore. It may be they feel better. It may be that they've talked to them in the family, but for whatever reason, they just say, you know what, thank you very much, but please don't, just discontinue the service. And then you have patients who actually graduate. You say, what are you talking about, Mark? There are actually members who improve to the point where they don't need palliative care. And we've actually had cases of members where I would not be surprised if they died the next year or two. And with the interventions we do, they actually get better and don't need palliative. So again, we monitor that as well. And then lastly comes, especially as a health plan, what is the return on investment? That's what my manager and his manager and the VPs are all asking. Now, the good news, there is literature. We actually published our results. It was about 1 year ago. It's April 2022 in the Journal of Palliative Medicine. And we confirm once again across multiple lines of business, palliative care does have a return on investment. And as Neil mentioned earlier, and we're not charging this to the member. So it's free to the member, the medical group, the doctor. Again, it makes their life easier at no cost. So if you look at this kind of group here, these are measurable and meaningful outcomes that we can monitor. And if you go into the next slide, so if you kind of say, oh, what are really the takeaways when you keep talking about this trust-based relationship? So one is we're in it for the long term with MedZed and our providers. Because again, if they're not successful, we're not successful, and vice versa. Communication. We talk to them, really, it's almost every day. And we still believe the telephone works, could be email, but it's nice talking to people, even using the video part and seeing everybody. But again, the communication is important because we need to coordinate. Remember, there's a palliative team, There's the usual medical team, PCP specialist, and there's the health plan when you're dealing with managed care. And those all need to work together and really take our complementary strengths and our unique expertise and add it to it. For example, we can add the mental health services if you need true behavioral health services. We may add a pharmacist if the provider doesn't have it. Yeah, both organizations may have social workers. So again, it's really the idea is working together. And as we do all those, indicators, as to how we're performing, it is not to say, you're doing a bad job. It's really for mutual improvement. What can we do together to make this program better, knowing that the program really does work? And again, as Neil mentioned earlier, it's really flexibility in the contracting, flexibility in the operations, and that, again, working together. Key, though, it's clinically working together because we're patient focused. So if you really want to sum it up all, one is always go back to that New England Journal article, palliative care works. It is absolutely the right thing to do. Patient, remember, they feel better, may live longer, there'll be less time in the hospital. And again, more is not always better. It's the less aggressive treatment. And it's not necessarily they're getting less treatment, they're getting different treatment. The support rather than maybe the chemotherapy or the radiation or the whatever. So again, the patient benefit, provider, we want to take some of the burden off of the PCP, help with pain management and other symptoms. So again, for the provider, this is a way to take some of the very sickest of your patients, and we can assist you with that. And for the plan, it's the right thing to do, and there's a return on investment. So in summary, this is absolutely the right thing. And like I said, I wish it were a medication because I can make a fortune off of selling it. But right now, we're giving it away for free. So anyhow, back to you, Neil.
Yeah, just going back to the prior slide, Eric, just to reiterate a couple of those key points on the trust-based relationship. So Marv is, an evangelist, I think I would say, for palliative care. I mean, he's seen the value of it. He's measured it in many ways. He really understands the nuances. And so that last bullet, it's the right thing to do for the patient, the provider, and the plan, is so true for palliative care. It's really a win-win-win. And so that's an example of a place where the trust-based partnership works really well. There are other places where it also works really well. So I described some of the other services that we deliver for HealthNet, and sometimes, and we also do them obviously for other MHPA health plans where it makes sense for them as well. So all of the things where the business and the sort of purpose of the organization and wanting to do the right things for the patients all kind of intersect. Those are the places where the partnerships are most successful. And then having some real sort of measurable, business-oriented dashboards and means of communication to track success, that's huge too. So having meaningful KPIs, having regular joint operations meetings, and really kind of seeing, not only from our heart, but our heads can see that this thing is really working as well, is really important. And then I think that those relationships, being able to communicate long-term, day-to-day, really not just sort of, shooting off emails, making, building these trust-based relationships is huge for success. And then I think I would add for MedZed, we try to be creative. We try to get inside the heads of Marv and his colleagues and say, we know certain things going on, say in the state of California. I wonder whether those things are a challenge for them. An example of that would be a new street medicine program, basically homeless care, which is a high priority for the director of our Medicaid program in California. And HealthNet wants to be, serving that population as well. So we've had now multiple conversations with them and are identifying opportunities in specific counties to be a street medicine provider for them, which partly came from us reading the tea leaves of what the state was wanting and saying, hey, would you like us to fashion this program? We have expertise in this area already, and it led to this next thing. So being creative and flexible and being able to, throw ideas out to each other to find those opportunities, I think is another key piece. So trust-based partnerships have a lot of pieces to them, some quite explicit, some interpersonal, some emotional, and some sort of thinking about the future.
And I would just add, when the flexibility, we had one patient who was living in his station wagon, and the palliative care provider would actually meet him either at a senior center or a Starbucks or somewhere, or at his car. And the key to his care was the telephone, not just reassuring him, but reminding him of appointments, reminding him to take his medicines. He gets the Friday tuck in. So you go, my goodness, you took care of somebody living in his car. By the way, he's on oxygen and still smoking too. And actually, it turns out the ED visits went down. Eventually, he cut way down on his smoking, and I'm not sure they actually stopped. He actually became interested in looking for permanent housing. But again, that was a palliative care team being very flexible, going to meet the patient where he is.
Yeah.
And probably the one other comment I wouldn't mention, we're talking mostly about adult palliative care.
Mm-hmm.
Pediatric palliative care, which by the way, is also a Medicaid or Medi-Cal benefit in California. It's a little different because the diagnoses are different. Kids are much more resilient. Very often what appears to be a life-threatening diagnosis may actually improve. So that, agreed, the patient may not have a long lifespan, but it's actually not life-threatening at the time. But again, there may be an exacerbation where it is. You're also dealing with members who don't have great verbal skills, these kids. You're dealing with the whole family, and the end of life discussions, although very difficult in adults, is very, very, very difficult when it comes to children. So again, most of what we talk about is adult, but keep in mind, this still applies to the pediatric population as well.
Great. Okay, Eric, why don't you flip to the last one? So our goal was to leave about 15 minutes at the end, 15 to 20 minutes at the end. We almost hit that number. It's about a little more than 10 minutes now. So we wanted to stimulate discussion among the attendees. And so if you have any questions, for sure, but we also have a couple of questions to try to get you guys thinking and contributing here. So Eric, I don't know if anybody has added anything to the discussion. I haven't looked in a while. Is there anything that you have so far?
No, I did not see any questions so far. Attendees can go ahead and submit their questions via the Q&A button. You guys gave such a comprehensive presentation. It seems like you guys have not left any room for questions or left anybody with questions at this time.
Well, if we don't have any, I'll just read those questions to kind of get people's juices flowing. So we're curious what your own experiences are with engaging providers in other collaborative partnerships. So it may not be palliative care, it might be other kinds of partnerships. It might be with just a small doctor group, or it might be a large integrated delivery system. But there are challenges to building long-term success. So we're curious to hear both the good and the bad of that. And then secondly, specific to palliative care that we talked about today, we're curious if you have a palliative care program, if you've thought about a palliative care program, if you have questions about how to start a palliative care program, what's your journey like in palliative care? So if either of those things are germane for you, we'd really love to hear from you.
Nothing yet. Go ahead, Marvin.
I don't know, I was just saying, and one thing in California, the health plans actually cooperate with each other. We have a coalition for compassionate care. We originally did grants from the California Healthcare Foundation, which were payer-provider partnerships that helps us develop contracts. So I don't think plans are really competing on palliative care. And it really is the right thing to do, where I truly believe all plans, all providers, all the members, everybody, when Neil says win-win-win, it is truly that where I think we need to get out of this thinking of it's something you compete on. This is really something we need to cooperate on and work together because, we say it over and over. It is absolutely the right thing to do. I'm sorry, you were saying?
No, I think that's very well said. I was going to ask about, right, so obviously this first question kind of touches on engagement with providers and engagement with members. Marvin had that great example about the gentleman living out of his car and how his phone was super important to him. Obviously, member engagement is super important this year, both it seems with evangelizing palliative care and also with the redetermination process and the ending of the public health emergency. Neil, I was wondering if you could talk a little, you touched on it really briefly, but I was wondering if you could talk a little bit more about kind of the member engagement tools or strategies that MedZed uses to really enhance these programs. And if you have found one that maybe is that you think is like the most effective, or one that you're particularly fond of.
Great question, Eric. And I think it's very apropos that you looped in redetermination, which is looming large, I think, for all of our plans. And the estimates that I've heard are somewhere between 15 and 20% of people might fall off the rolls. Now, some of them, that might be for good reason. They may have found a job and have income and actually don't need to be on Medicaid anymore, and we wish them well. But others were really worried that they will not know or be able to follow through to retain their benefit, and that it could have bad implications, bad consequences for their health and their well-being. So we've actually wrapped that into our engagement strategies with all of our patients across all three of those programs I described earlier, is a component to engage patients and to ask them at every encounter whether they are aware of this, whether they filled out the paperwork, and whether they are at risk for losing their benefit. So, and then we have, we can assist them with filling out the program, the materials if they need to document. So yeah, that's all part of the strategy. It's wrapped into the patient engagement strategy and the patient support strategy, if you will. So back to your question, which is how do you actually do all this work? So it's sort of a tiered approach. There's multiple strategies. The first one is the simplest one, and that's to call people on the telephone numbers that we have for them, all the phone numbers at different times of the day on different days. So to try to reach them. We have some success with that, but the vast majority, we're not going to be able to enroll that way. So then the next step is to go to the address or addresses we have for them. But sometimes we have no address, or we only have the address of a social services agency where they might be able to pick up their monthly Social Security check. So that's not helpful. If we go to an address and they're not there, we'll go into the next door neighbors and knock on their doors and ask them if they've seen this person, if they know this person. Sometimes that will be helpful. We'll use community networking. So the longer we're in a community, the more likely we are to know somebody from our program who knows this person we're looking for. And so we can start to use our own networks of patients and caregivers to try to find people. We also have strong relationships with food banks, churches, homeless encampment people, and shelters, of course. So we network and we ask if they know this person. The next thing is to actually go back to the health plan and to look at their claims data and see if this person has shown up in the emergency department recently, filled any prescriptions, which might give us clues as to where they're located. And then, if they actually are admitted again, to then go find them when we have them as sort of more captive as an audience, and to engage them that way. So there's a sort of a series, almost a hierarchy of ways to go and look for these people. But I will say that all of that sounds good. It doesn't work if you don't have really motivated people out there who see this as their personal mission to help people who are really struggling. And so it's the heart of our team. It's actually the largest cohort of people in our company now are community health workers. And we have a whole bunch of training strategies, and we're looking for certain kinds of people who have demonstrated that they care a lot and that they're going to go the extra mile to find these people. I often say, a lot of it is shoe leather. You got to do a lot of looking around and knocking on doors and going through gates and not being afraid of a dog sometimes to go and go that extra mile. And we have just amazing people who are willing to do that. I think that's a huge piece of it as well.
I think that's very well said. So still no questions have come in. So I know we only have a couple minutes left. So before I wrap up, I wanted to give you guys both the opportunity, if you had any last words or anything you wanted to share with the group before we go ahead and wrap up.
One thing I'd like to comment on, in California, I'm really very proud of the palliative providers. Because remember, if you go back 7, 8 years, no one quite knew what a program looked like. And our providers have really stepped up to the plate, created palliative programs, added community healthcare workers, added social workers, did home visits, 24/7 coverage, chaplain. So I think they deserve a lot of credit for what they've done. And the health plans, although often maligned, really step forward. And remember, the SB 1004 mandate was only for 4 diagnoses: cancer, heart failure, severe lung disease, liver failure. Most of the health plans have gone well beyond that. So even though it's not, quote, a benefit, the health plans are providing it. And we've even gone beyond Medicaid. Remember, it's not a Medicare benefit, it's not a commercial benefit, but most plans are providing this to their members. So I have to say, in California, we're very proud of, I think, the plans and the providers for stepping forward and making palliative care happen.
Yeah, and I'll add 2 things to that. The first is that MedZed has been providing palliative care since long before it was mandated by the state. I call that palliative care with a lowercase p and a lowercase c. It's part of how we take care of people. It is addressing their needs and recognizing that we're not going to be able to cure every diagnosis, but we're going to be able to provide care for people and help them live the best life they can with life-limiting illness. It was only when the state passed a bill and enacted the law that there became a formal capital P, capital C palliative care program, and we built all the infrastructure around it. But we've trained our people from the beginning to address all of those needs. I mean, when I was going through my training, there was no such thing as a palliative care specialty. And that was just part of what we all learned, what Marv learned as well. That's the first thing I'll say. The other thing I'll say is that regarding partnerships, Marv has been a practicing physician and then in a health plan. I've been a practicing physician and I've worked in a health plan, several of them actually. And so having both perspectives, I think allows us to understand the needs of the other. And I find it part of my job to make sure that everybody in my organization understands and has a culture of cooperation with health plans. Many providers see health plans, and I'm sure you all know this on the call, as sort of the necessary evil, almost the evil empire that we just have to live with. And we don't look at any of our health plans that way. We look at them as great partners. They have assets and insights and people that we don't have. And we have stuff that they don't have. But we all have a mission together to take care of really needy people. And so by bringing all of our assets together and by collaborating, we get a lot farther than if we did it one or the other, or even at odds with each other. So I actually spend a fair amount of time when people come into our company, depending on what their prior experience was, making sure they understand that and reinforcing that over time. I think that's huge.
And also to remember, members can shift back and forth. So they could be in palliative, they may get better and go to the health plan's case management. Or Neil's group may need true behavioral health. Well, that's a regular benefit. So it's kind of back to us. Community healthcare workers, we probably both have community healthcare workers. Pharmacists, not all of our providers have pharmacists. Our pharmacists can help out. So once again, it's the strength of each organization and being synergistic in the best care for the member, flexibility, kind of fluidity in it, moving the patients around. But I'm really proud of what we've done, what our providers have done. And really, it's I think shows you that we put the clinical, back, we put the care back in healthcare. That's probably my summary.
How can you end with, how could you have a better end than that? Perfect.
I can't follow
Thank
that.
you.
That's pretty great. Someone needs to trademark that and use it as a slogan. Well, great. Thank you both so much for the very informative and insightful presentation. As a reminder, if you have questions that come up, please feel free to reach out to the MedZed team directly. Or once again, you can connect with MHPA and we'd be happy to go ahead and make that connection for you. Once again, you'll be able to find a recording of this great presentation on MHPA's YouTube channel. And then finally, once again, thank you again to Neil, Marvin, and the entire MedZed team for sharing their expertise and leadership on this really important issue. And finally, thanks again to everybody who joined us today. We hope that you found the presentation to be interesting and insightful, and we hope you join us again next time. Thanks, everybody.
Thank you, Eric.
Thank you.
Take care.
Great job. Bye
Bye,
now.
everybody.
Bye.